I think we'll get started for our afternoon session, and I'm going to turn the baton over to Dr. Seacrest, who is Dr. Seacrest is at St. Pat's in Missoula. I always mix up St. Pat's, St. Pete's, St. V's. I wish they had slightly different names here in the state of Montana, but they don't. Anyway, Dr. Seacrest runs the Montana Spine and Pain Center, and has been involved with the Montana Pain Initiative from the beginning, which has been wonderful. And I'm going to turn the mic over to him, and he's going to lead the afternoon session, which is about persistent pain management and sort of advanced issues, as we like to call them.
So we're going to change direction. I'm not going to, I think there's a half hour set aside for me to talk to you. I'm not really going to talk to you for a half an hour because, as I said, we're going to try to change the direction in the afternoon and really make this much more interactive. We're moving towards a situation which I think everybody in this room has probably been in, and that is when things start letting you know that, like Dorothy, you're not in Kansas anymore. The relationship you have with the person in front of you is getting either messy, uninterpretable, or difficult. And you don't know why that's happening. And this is not your standard pain patient that, in some ways, you heard about this morning. Someone who comes in, you take at face value, you start to treat that condition, and it responds as expected, and everybody is happy ever after, and you go about your business of managing the pain, the patient, and nothing happens. Now, how many chronic pain patients do you know that actually occurs in? Not many. And I want to bring up the point that one of the things you have to really do is understand that acute pain and chronic pain are two totally different things. And then some people would also say that cancer pain is a totally different animal. What we're really going to be focused on this afternoon is the chronic pain patient in its entirety and the complex chronic pain patient, because I will guarantee you that when you see what you consider a non-complex chronic pain patient, the future is to begin to see a complex chronic pain patient at some point, because the vast majority of patients who continue to put up with chronic pain begin to change in front of your eyes. So that's, in some ways, one concept that I want you to really focus on this afternoon. The other thing I want you to focus on is some things that have been alluded to this morning, and that is there really are multiple domains. When you talk about the biopsychosocial model, it's easy to say that word. It rolls off the tongue. It is so incredibly intelligent sounding. What does it mean? And the longer you deal with these patients, the more you understand what it means. And to me, it's evolved over a period of time in dealing with patients such as this, that you really do have to understand that when you're faced with a chronic pain patient and they show up and say, I need some help, there are three domains that you really need to always go through and make sure you're paying attention to these domains. And the first one is what I would call the physiologic domain. Now, what does that mean? That means that, what's wrong with a patient from a pain generator standpoint? What's the disease process? Is it rheumatoid disease? Is it neuropathic disease? Has this person had multiple surgeries? Does this person have something in their disease process that's getting worse? Is the arthritis getting worse? Or is their back beginning to decompensate again? And what you're seeing in front of your eyes, a progression of the physiologic disease or not? The second domain is the psychological substrate that you have to work with. And quite frankly, that's where the Osler comment comes in with, it's better to know the person with the disease than the disease that the person has. Because every one of us has a different psychological substrate that when we're presented with a physiologic insult, we're going to respond to that in a whole host of different ways. And every step of the way, that substrate that you're presented with, and then the way the substrate changes over time is going to affect your treatment decisions. To focus purely on the physiologic, what's happening to the disc above the fusion, what's happening to their knee, is to miss the big picture. You got to pay attention to it, but I would really say understand the psychological substrate going in and all along the way. The third piece that complicates it, and quite frankly, chronic pain management would be relatively hard if it weren't for this piece, and that's the substance piece. As you understand, all of you, that patients, once we begin treating chronic pain, and once substances are involved, all of a sudden we create new diseases, we uncover new diseases, and in some cases we're simply presented with a disease that we didn't recognize when it showed up at our doorstep. And we focused on the physiologic component and we focused on the psychological component, but we really misinterpreted the relationship to substance. So those are the three domains. Those are the three domains that we deal with in Missoula every day. And if I've said this before and people have heard me say this in the audience, if I had my perfect way of understanding a chronic pain patient, it would be to have a dashboard with 3 dials. And one would be the dial for the physiologic complaint, one would be the dial for the psychological complaint, and the third would be the substance dial. And by balancing the risk and how those dials are looking at every visit, I would have a pretty good way of monitoring whether what we're doing is a net gain for that patient or whether we're losing on one of those three measures. So those are the 3 measures that we're really going to focus on this afternoon, and we're really going to focus on setting context for you. Not so much algorithms, not so much what do you do, what prescription do you write, what dose of methadone do you use, what are the side effects of methadone. You're going to hear some of that, but what I really want you to do is focus on those 4 patients that you have in your binder that are very typical of the patients that show up in our offices every day with the same amount of information. And I want you to start thinking about what you've heard this morning and what you're going to hear this afternoon and begin jotting down some notes of how would I deal with that patient? What do I need to know? What am I starting to think about in terms of the biggest issue here? Is it the physiologic piece? Is it the psychological issues? Am I not seeing the substance piece? What's going on with these patients? Now, they're purposely vague because at the end of the day, what we're going to do is spend about an hour, the rest of the day, in bringing the panel members up, and then as a group, we're going to go through those 4 patients and really sit down as a group and try to figure out how you would approach these patients. What information is critical based on what you've got there? What else do you want to know about that patient? And then how do you want to begin to craft a way that you would approach this patient to both understand those 3 domains and then begin to craft a treatment plan that you could conceive of trying to utilize consultants and utilize the resources you have to try to move this patient in a positive direction. So the first speaker today is going to be Dr. Davis, Pat Davis. He's a clinical pain psychologist that works with us at St. Pat's, and I think that it's very compelling that the first person you hear from this afternoon is a psychologist about the evaluation and how you approach the neurobehavioral aspects of chronic pain, because when it all boils down to the long haul, chronic pain is a neurobehavioral disease at its core. And if you can't impact that, you can do all the procedures you want to do, you can throw all the medications you want, and you can keep them safe from the substance issues as much as you want, but you will not impact their lives, chronic pain patients' lives, in a way that's going to put them in a better place, which is really what the goal is to put them in a better place and reduce the amount of harm that either they're going to do to themselves or we're going to do to them as a system as we go forward. So I'll turn it over to Dr. Davis.
Yeah, so I'm Pat Davis. I work at the Montana Spine and Pain Center with Dr. Seacreast and a few of the other folks that are here today. And my topic for today is behavior medicine assessment and intervention. In a sense, I'm kind of following a little bit in the shoe steps of David Segerstrom, who covered some of the kinds of things I'm going to be talking about before lunch. So I'll try not to be too redundant and try to focus more on perhaps some information that he didn't touch on. I do want to express my, I guess, kind of appreciation or gratification for the focus that's been focused today, so far today, on the importance of psychosocial factors in understanding the total pain experience. Almost everybody that's talked, in fact, perhaps everybody that's spoken so far today, has had some focus on that issue. And it's really a very important issue. When you read the scientific literature and you look at this issue of what makes a difference in the progression from acute pain states to chronic pain syndromes or chronic pain states, what comes up over and over and over again is that psychosocial variables are far more powerful in predicting the progression from acute to chronic pain than are physical variables. And so the focus that we've had today on the importance of these psychosocial variables, I think is very important and very gratifying to hear. Another thing that I just wanted to follow up on that's been mentioned by a couple of the previous speakers today is the importance of focusing on function and on quality of life, in addition to focusing on pain relief. Especially when we're talking about chronic pain, we can really get going in the wrong direction with patients if we try to lead them to believe that the goal of their treatment is going to be significant pain relief. If they were going to achieve significant pain relief, they wouldn't be chronic pain patients by virtue of the definition of that category that we put them in, chronic pain or persistent pain, I guess, as I should say. These are people whose pain is not likely to go away, although we may help them to diminish it somewhat. I think what we really want to shoot for, and the message that we want to communicate to them, is that we can help them to manage their life more effectively in a way that will allow them to diminish their pain somewhat, certainly diminish the impact of the pain on their life, but will help them to significantly increase their ability to engage in the functional activities that bring meaning to their life and significantly increase the quality of their life. So those are just a couple of things that people have already addressed earlier today that I just wanted to review and rehearse. In a moment, I'm going to switch to a slide that's got three potential take-home points, things that I hope you will take home from this presentation. But before I get to that, I've also got a couple of other objectives, I guess, that I want to communicate to you. In conversations that I've had with healthcare providers in the past, a question that consistently recurs and consistently comes up is that of when should a primary care provider make a referral to a mental health professional, to a behavioral medicine specialist, or to a multidisciplinary type of treatment setting? There was some discussion just a little bit earlier. Janice was talking, I believe it was Janice, showed us the slide with the yellow flags and talked about those kinds of indicators, and those are some good indicators. But I want to talk a little bit in my presentation today about how to know, some signs for when that type of a referral is appropriate. Another related concept that has come up in previous conversations that I've had with primary care providers and other healthcare providers has been whether or not there's some kind of tool that they can use to help them make that sort of decision. Well, certainly reference to that table of the yellow flags can be helpful in that regard. But in preparing for today's presentation, I did a bit of a literature review trying to determine whether or not there were some standardized tools available that had been demonstrated to be effective with regard to predicting the progression from acute low back pain anyway to chronic pain. And indeed, there's a number of such tools. And so I pulled a couple of those out that seem to be perhaps the most well-validated, and they've been included in your handout. One is the Aribo Musculoskeletal Pain Screening Questionnaire, and the other is the Distress and Risk Assessment Method, or the DRAM. These are relatively brief questionnaires. There'd be a little bit of a learning curve in terms of incorporating it into your practice and learning how to score it. But once you had made a little bit of an effort to do that, these are things that you could have patients fill out in the waiting room Your clinical staff could score them very easily in a little algorithm that you might build into a spreadsheet program. And you could get a real quick assessment with new patients or patients who have not been in your practice very long, or maybe they've been in your practice a long time, but they've got a new pain complaint. You could get a fairly early indication of whether or not they're the kind of individual who's likely to progress to chronic pain. And if that's the case, then that's somebody that you might want to consider referring for behavioral medicine evaluation, intervention, or multidisciplinary care really early on in the treatment process of their pain complaint. So those are a couple of things that I wanted to get out of the way before I got into the substance of my presentation. Let's see if this remote control works like I think it would. Oh, look at that, it does. So I've got 3 take-home points I'm going to start and end with today. The first of these, Dr. Seacreast already shared with you, and that is that chronic pain is a neurobehavioral disorder. I guess, is there somebody that's doing timing that I can watch so I know how I'm doing, or shall I watch my own watch? I guess maybe I better watch my own watch. That's like a halfway through warning. Okay, well that's good. Are you going to give me that?
No, right back there, she'll have a big black sign with white letters on it.
Are you serious? Oh, that'll be great. Okay. Okay, so the first take-home point, chronic pain is a neurobehavioral disorder. Neurobehavioral, that's kind of like biopsychosocial. It's a pretty fancy word, sounds really cool. What exactly does it mean? Well, it might mean a number of different things, but what it means to me is if you break the neuro and the behavioral into 2 parts, when we think about the impact of the central nervous system in particular, perhaps the peripheral nervous system to some degree too, but you know, the gate control theory of pain, which probably a fair number of people in this room have some familiarity with, has a significantly well-known history, I guess, among people who specialize in treating pain at this point. And the gate control theory helps us understand how certain psychological factors may contribute to enhancement or magnification of the experience of the symptom of pain. And that happens as a function of the way the nervous system processes the pain signal and how that's modulated by affective and cognitive types of phenomena. If you follow some of the, if you read the journal Pain or the Journal of Pain and those types of literature sources, you'll have some familiarity with a lot of work that's being done these days in an area that's referred to as neuroplasticity or central sensitivity syndrome. This is an additional way in which the functioning of the nervous system and how the nervous system itself actually changes, both in its function and in its structure, can affect the way that the pain signal is processed. These are changes that happen in the body and the nervous system in the absence of ongoing nociceptive input. So that's one way of understanding the neuro part of chronic pain being a neurobehavioral disorder. There are actual changes that take place in the way the nervous system processes the pain signal. The behavioral part has to do with behavior. But we want to expand behavior between talking about simply physical behavior, like we talk a lot with people who have chronic pain about activity pacing. That's a very clear sort of physical behavioral variable that makes a difference in their adjustment to their pain. But there's also cognitive behavior, and you could even really, in a sense, kind of think about affective behavior. The way people think about their pain, the way people respond emotionally to the experience of pain can affect the way the nervous system processes the pain signal, and it can also, the emotional, the cognitive, and the behavioral reactions all kind of interact with each other, so that the way a person thinks about the pain or the way that they react emotionally to the pain can affect their physical behaviors. For example, whether or not they pace themselves effectively, whether or not they confront an issue that we'll refer to as fear avoidance in an appropriate sort of way. I'll refer to fear avoidance a couple times probably before I get done today, but I'm hopeful that Nelson's probably going to talk about that a little bit, just a little bit. Okay. Very, very important concept, and if we don't talk enough about fear avoidance and you come away from my talk and you come away from Nelson's talk still kind of wondering what fear avoidance is, I encourage you to ask about it during the question and answer period at the end of the presentations today. The second take-home point is that early referral for behavioral medicine assessment and intervention may increase the likelihood of a positive treatment outcome. And I think that this is just very, very important because psychosocial factors are so predominant in predicting the progression from acute to chronic pain. And again, these tools that I've provided you with, as well as reference to that table of yellow flags that Janice presented earlier, can help you decide which patients are patients that ought to have that type of referral pursued early on. The third take-home point is this idea of supporting the patient's movement toward paradigm shift. Now, another thing that I'll talk about a few times as we move forward through this segment of the presentation is how do we get a patient to shift in the direction of what Dr. Sechrist referred to as the biopsychosocial model. When we think about pain and pain that we experience, we attribute that pain to different kinds of things. And the traditional sort of way in which we do that, and a way that's really reinforced by all kinds of cultural elements in our world today, is to view our experience of pain from a biomedical or purely physical sort of standpoint. So you might say that our attributional style when we experience pain is that we have a disease or we've got an injury of some sort. And in many cases, especially with acute pain, that's a perfectly appropriate attributional style. When your pain is new and you haven't had it before, it makes sense to assume there may be some kind of injury or some sort of disease process, and you want to go to the doctor and get it checked out. But for people who have chronic pain, a different type of attributional style really becomes more appropriate, and I would call that the biopsychosocial attributional style. So if I get up in the morning and I'm having an episode of low back pain, I may want to be concerned that I might have herniated a disc or cracked a vertebrae or something like that, but I might also want to think about whether or not I've been under a lot of stress at work lately, whether or not I've been having interpersonal problems with family members, whether or not I've been having other kinds of psychosocial sorts of stressors going on in my life that may have contributed to that flare-up of low back pain as well. If I consider those kinds of factors, that's what I'm referring to as a biopsychosocial attributional style. And we, with chronic pain patients, if you as a primary care provider or some other type of healthcare provider that's going to refer a patient for behavioral medicine evaluation or is going to refer a patient for workup at a multidisciplinary treatment center, if you're going to do that, you can be helpful in that process by helping to start moving that patient in the direction of thinking in this biopsychosocial manner. And that's what I mean by supporting the patient's movement toward paradigm shift. Now, really the substance of my presentation today is to talk about what's involved in behavioral medicine assessment and intervention. And so I'm going to talk for the next few minutes about some issues that are relevant to the assessment part of that topic. And this is just an overview slide. So the next several slides are just going to follow up on each of these things. When doing an initial assessment, a behavioral medicine type of assessment, I think it's really important as, I don't know if Dave said this during his presentation, but it's in his slides I noticed. It's really important to remember that one size does not fit all. Not all pain patients are the same. We can't have just a cookie cutter sort of approach to providing treatment to people with chronic pain. Dave did refer to the work of Dr. Engel, who is well known really for, I think, perhaps even coining the phrase biopsychosocial, but certainly was influential in getting that movement going in the first place. Dr. Engel was also interested in searching for the pain-prone personality. And there were a number of other people who joined him in that kind of work many years ago. The conclusion has kind of been over the years that there really doesn't appear to be a pain-prone personality. And what that points to is the fact that we need to develop individualized treatment plans for these patients. Just because we decide that psychosocial variables or psychosocial factors are a part of the picture doesn't mean then that the person fits into a neat little category and there's just a prepackaged intervention that we can give that patient and all patients who fit in that category. So when we do a behavioral medicine evaluation, we want to develop an individualized treatment plan. We'll be looking for whether or not there's a need to refer people for additional assessment, for example, chemical dependency or sleep study, and whether or not there's a need for additional kinds of referrals. Again, following on Dave's remarks earlier today, if somebody has severe post-traumatic stress disorder and they've come to the pain clinic, we might not have the resources to treat their PTSD to the extent that it needs to be treated, so we might want to refer them to someone who's a specialist in treating that particular comorbid disorder. Along those lines, we're looking to identify psychological comorbidities, which we may be able to treat within the context of the behavioral medicine treatments that we're providing, within the context of our multidisciplinary treatment program, or which, again, we may need to bring in the involvement of other outside players who can address those issues. Another thing that behavioral medicine evaluation can be helpful with is estimating risk for misuse of opioid medications. And of course, we're always trying to get a sense for who's at high risk and who's not at high risk for that sort of thing. And while it may not be the primary purpose of doing a behavioral medicine evaluation, it's another data point that can be helpful in the overall care of the patient. So as a behavioral medicine specialist, I get referrals, and people who do the kind of work that I do get referrals from different sorts of places. In many, many cases, in the setting that I work, which is a multidisciplinary treatment program, we get many referrals from primary care. Sometimes the primary care provider simply wants some feedback, wants some information on how to proceed with their patient, but doesn't really want us to take over their care and doesn't necessarily even want me as a psychologist to be involved in providing behavioral medicine interventions. On the other hand, sometimes they do want me to become involved in providing those kinds of interventions. And then finally, sometimes referrals will come from within the interdisciplinary or the multidisciplinary treatment context. Sometimes we'll take on a patient who doesn't get involved in the behavioral medicine component of the multidisciplinary program initially, but as treatment progresses, it becomes increasingly apparent that that type of involvement would probably be helpful. So in doing an initial evaluation, kind of consistent with the usual way that psychologists do psychological evaluations, we try to take a multimodal approach. And to me, what that means is we want to obtain data from a number of sources. So one source is the medical record. Another source is the interview, and another source is objective psychological testing of some sort. These are some of the reasons that doing a good record review can be helpful. It kind of points to the fact that if a mental health professional is going to work in this kind of a medical setting, it's really helpful to develop some familiarity with medical jargon, with the typical types of pain-related diagnoses, and various issues that are relevant to having a coherent and intelligible conversation with a pain patient. That was my 15-minute sign. That was good. Thank you. Okay. And that really illustrates to me my need to move right along. So I won't go through each of these bullet points. You can see them, and they're in your handout. But there's a number of things that are valuable aspects of doing a careful record review. Kind of a little bit of the heart, I think, of what I want to talk about today is this objective assessment stuff, because and I think people may not really be aware of this, but over the last 20 years or so, there's been a great deal of research that's been done by psychologists looking at what I would call relevant clinical characteristics of pain patients. And these are the kinds of things when you're doing an assessment, a behavioral medicine type or a psychological assessment of a pain patient, you want to try to identify whether or not these relevant clinical characteristics are present in that particular patient. Whichever constellation of those characteristics turn out to be present, if any, are going to constitute specific treatment targets of that individualized treatment plan that I was talking about earlier. So this list that's on the screen right here is not exhaustive, but reflects quite a few of the types of psychological constructs that are relevant clinical characteristics in working with the chronic pain patient. Of course, pain, of course, is a relevant construct. We assess that. There's many tools you can use to assess pain. Some of them have been talked about earlier. The one that I've got reflected here was actually mentioned earlier today, too. That's the brief pain inventory. There's a short form. That's what the SF stands for, and that's what we use. Another relevant clinical characteristic that comes up a lot with people with chronic pain is catastrophizing. This is kind of getting really anxious, blowing things out of proportion, making mountains out of molehills, having intrusive or deliberate ideation about ending up in wheelchairs and spouses leaving the patient and never being able to work, that kind of stuff. That's been shown to be associated with poorer outcome from pain treatment. So if that's present, we want to address that. So we want to assess it, and there's a couple of tools that have been developed that can be used for that purpose. The Coping Strategies Questionnaire Revised and the Pain Catastrophizing Scale is what the initials stand for. I mentioned earlier this concept of fear avoidance, which is basically the idea if you've done something and it hurts, you're going to avoid trying to do it again. It's a natural common sense reaction. But in the long run, when pain persists, it can become maladaptive because it contributes to deconditioning and maladjustment of the musculature, such that when a person then begins to try to engage in that kind of behavior, it becomes painful, not because the underlying illness process or injury is still present, but just because the musculature has become deconditioned. The person doesn't realize that. They just feel the pain, the muscle burn from the unusual exercise, and they assume that the underlying disease process or injury process is still active, so they continue to avoid that activity. Physical therapists need to be very aware of this particular dynamic because they can work very effectively with patients who have that dynamic if they're aware that that dynamic's present. And we as behavioral medicine evaluators, you might say, can help to make it clear to the physical therapist that this is likely to be an issue for the patient. We do try to, at least in my role, I try to help with the assessment of risk for opioid misuse. I use one of the measures that was discussed earlier. It's the screener for opioid addiction in pain patients. It's got a revision now, so the hyphen R there. There's a number of maladaptive beliefs that have been documented to be present in the minds of patients who do not tend to do well in terms of treatment outcome. There are a number of tools that have been developed for assessing those. I think we all completed part of one on the little white paper we filled out at the beginning of the meeting today, actually. We don't personally use that particular survey of pain attitudes questionnaire. Not that it's a bad one or anything, we just don't use it, but we do use a thing called the cognitive risk profile for pain patients, which attempts to measure a number of problematic beliefs and attitudes that pain patients may develop, and which may interfere with their making progress in rehabilitation. Of course, we want to assess anxiety and depression. There's a variety of tools that are commonly used for that purpose. We use a thing called the Depression, Anxiety, and Stress Scale. It's kind of nice because it has norms for chronic pain patients, general psychiatric outpatients, and then non-patients as well. There's been reference made earlier today to the need to assess readiness for change. If you think about it, when a person needs to make lifestyle changes, and we're really talking to some degree about lifestyle changes as well as cognitive changes for these chronic pain patients, if they're going to increase their function, if they're going to improve their quality of life, they're probably going to have to engage in some kind of lifestyle change. And some people are more ready to do that than others. And so we kind of have a word for people who are not ready to do that. We call them pre-contemplators. And that's based on a theoretical model that's sometimes referred to as the trans-theoretical model, sometimes referred to as the stages of change model. There's a questionnaire that we use called the Pain Stages of Change questionnaire, which gives us a sense, an idea of whether or not a person is a pre-contemplator or not. The importance is that it goes back to this idea of the individualized treatment plan. If a person's a pre-contemplator, our approach to intervening with that patient is going to be somewhat different than it's going to be for someone who's not a pre-contemplator. We may have to spend a little bit more time educating them and trying to get them on board. Dave talked a little bit about acceptance, and in fact there are a couple of questionnaires that we use to assess that as well. The Chronic Pain Acceptance Questionnaire and the Pain Interference, I can't remember what PIPS stands for. It's Pain Interference Perception Scale maybe, but it's another questionnaire that's intended to measure this psychological construct of acceptance. And then self-efficacy is another construct we try to measure. Self-efficacy refers to the degree to which a person believes that they have the ability to solve problems that they're confronted with in their life. And this pain self-efficacy questionnaire is helpful in assessing that with regard to people who have persistent pain and helps us to understand their level of self-efficacy in that regard. Finally, I've got listed the multidimensional pain inventory, which is a commonly used questionnaire that helps to identify a variety of different aspects of the chronic pain experience, and actually classifies or attempts to classify people with persistent pain into one of 3 different groups, which have differing treatment implications. So the third part of our multimodal assessment then is going to be the interview. I won't go through all these bullet points in the interest of time, but in the interest of review, I'll say that the overall behavioral medicine evaluation then is multimodal, involves record review, involves this kind of objective assessment that we were just talking about, and also involves a careful interview that is in some respects kind of a standard psychological interview, but also is going to include some focus on the history of the pain syndrome and the current experience of the pain syndrome, because that information is going to provide useful behavioral data. We can also engage in some ongoing assessment. Again, in the interest of time, I'm just going to skip forward here and talk a little bit about intervention. So shifting gears now from assessment to intervention. Here we are back at this inducing paradigm shift idea. Especially for people who are pre-contemplators, we may need to do some work to help get them on board with regard to this biopsychosocial attributional style that I was talking about earlier. We need to make decisions about whether to put the person in group treatment, if group treatment's available, or individual treatment, or maybe both. Again, one size is not necessarily going to fit everybody. We do tend to have this cognitive behavioral focus. We also try to provide opportunities for experiential learning. I've kind of touched on these things, but quickly, this paradigm shift involves moving patients away from a biomedical viewpoint to a biopsychosocial viewpoint, moving them away from the passive recipient of medical management to a position of feeling that they're in charge of self-managing their pain. For people who are pre-contemplators, we want our interventions to be appropriate to that stage of change, so we may have to engage in some motivational interviewing strategies for those individuals. And again, we're going to do experiential learning where we can. There are certain people who might not want to put into a group program. You know, a group program's good because you can put a bunch of people in there and you can provide a lot of education. You can reach more people more quickly at less cost. So if you can do work in a group setting, that's a good thing. But there's some people you might not want to have in the group. And behavioral medicine evaluation helps us to identify who those people are, either to keep us from putting them in the group in the first place, or to help them get ready through some individual work for subsequent participation in the group program. So that would include the pre-contemplators, people with significant antisocial or borderline personality characteristics, people who have chronic and unstable mental illness, people with severe social phobias, and then sometimes people, based on their individualized evaluation, are going to have needs that just aren't going to be addressed by the content of the group, and so some individual work with those people may be indicated as well. This is another slide that just kind of illustrates the same one-size-does-not-fit-all concept, and again, in the interest of pain, I'm going to skip right over it. I want to talk just a little bit about CBT. That's another buzzword. Everybody talks about CBT, cognitive behavioral therapy. Again, what is it? Well, so in the few minutes that I have left in my presentation, I'm going to tell you a little bit about that and maybe a couple other things. Dennis Turk, who we are extremely fortunate to have speaking before us on this stage tomorrow, has written a chapter and many other chapters and perhaps books, but in particular, he's written a chapter in a book that I have on my shelf that I have taken this slide more or less from. He talks about the 4 basic components of cognitive behavioral focus. And these are education, skills acquisition, skills consolidation, and generalization and maintenance. And just very briefly, education kind of fits into this whole category that I've just been talking about, what I've been calling paradigm shift. He refers to it in that particular chapter as reconceptualization. And again, it's helping the patient reconceptualize the way that they think about the pain. Skills acquisition is teaching them specific skills that they can use to manage the pain. Skills consolidation involves cognitive and behavioral rehearsal of those skills. And then the final component is generalization and maintenance, which hopefully helps the patient to incorporate those skills into various diverse aspects of their life and help them prepare to utilize those skills once treatment has come to an end. Just to focus in on a few aspects of the cognitive behavioral focus when we talk about education and reconceptualization. This slide illustrates a number of the things that we provide education about and that we hope will help cause that reconceptualization process to take place. This slide points to a number of the specific types of behavioral and cognitive skills that can be useful to the patient with persistent pain to help them learn how to more effectively manage that pain or to cope with it. So, and we focus on all of these things in our program at our center. Experiential learning, I think, is particularly useful. Experiential learning is when you have the patient in the office and you give them an experience that demonstrates to them on the spot that these skills that you're teaching them make a difference in their experience of pain. And there's a number of ways in which, if you're paying attention when you're working with a patient, that you can actually make this thing happen in the clinical setting. And it's always really kind of exciting when that opportunity presents itself and if you're able to carry it off successfully. Values, clarification, relaxation, mindfulness, assertive communication, active listening are some good examples of experiential learning that can be facilitated with the patient in the clinical setting with relative ease. And then, of course, review and rehearsal of these kinds of skills over and over and over again with the patient each time you see them is very useful. So this brings me back to my 3 take-home points. I apologize for talking so fast, but I think I'm almost on time. Chronic pain is a neurobehavioral disorder. It's strongly influenced by the patient's own behaviors, which can contribute to the perpetuation of their difficulties with pain. And it's also influenced, we believe, by the way the nervous system processes the pain signal. And the way the nervous system processes the pain signal is influenced by emotional reactions, by the way the person thinks about the pain, their beliefs and their attitudes, as well as by their behavior. Take-home point number 2 is the earlier you refer people who are likely to have needs with regard to psychosocial intervention, the better. And the third take-home point is if you decide to make that kind of referral, help us out by sort of getting the patient oriented in the direction of paradigm shift in the first place. And that brings me to the end of the presentation. Thank you for your patience, and we'll be talking with you later. Thank you.
The one thing that I would like to stress is that, unlike a lot of things that we do in medicine, when you're dealing with a chronic pain patient, you're actually running an experiment. And the first part of the experiment is to create a hypothesis. And I've given you sort of the 3 variables in the experiment that you want to sort of create a hypothesis about. One of the things that we utilize the psychological evaluation for is to really get a feel for who that patient is. Now, I don't want you to think you're going to send it, you're going to get the psychological report, and all of a sudden you understand who that patient is. Your most important psychological tool in the management of a complex chronic pain patient is watching behavior over a period of time. And one of the things that can help you is create the initial hypothesis with a good, solid evaluation, a psychological evaluation, but that doesn't mean you switch it off and you just assume that you already understand what that patient's all about. You're going to change that hypothesis as you engage with that person over a period of time. One of the most useful pieces of information we get is from the physical therapist because they deal with the patient on a one-on-one basis more and see how they behave over a period of time. So I would encourage you not to sort of think of physical therapy and psychological therapy as 2 different things. A good physical therapist has more psychologists in them than they like to admit. Correct?
That's absolutely right.
Tell us all about that.
Okay, well, nice to see you all again. Well, that was really well put. I'm going to see if I can elaborate on that. When it's all said and done, with people that have challenging pain issues, we're trying to do 2 things. We're trying to improve their functioning and decrease their pain. And I think that basically sums up everything that everybody's trying to tell us today. And when I see any patient, any day, I'm always thinking, how can I improve their functioning? How can I try to decrease their pain? And boy, it sounds easy, but it sure is difficult in practice. And part of that goes down to there's some really basic issues that we're still unclear about. when we're trying to understand how this whole pain process works, we have people coming at it from all different angles. And there's people that are studying this from the smallest level, the receptors, the nociceptors at the periphery that are taking in information, to people that are studying it at the highest levels, at the psychological processes involved in this. And often they don't communicate with each other. And as physical therapists, we're left in the middle trying to sort out the material and decide, well, how can we pay attention to the information here on the very basic science level of how pain works, and how can we understand it here on these how psychological processes are affecting things. And that's a challenge that we deal with every day. This is this model that I talked about before, and I talked about it earlier basically just to bring across the point that most musculoskeletal pain, I would say nearly all musculoskeletal pain, is initiated because of a process where the tissues are dealing with more stress than they can effectively handle. And a great deal of pain, even chronic pain, can be maintained by those tissues having difficulty dealing with stress, their actual ability to deal with stress. And so as we run away from the biomedical model and go to the biopsychosocial model, it is important to realize that these things still occur. And just because they have not been picked up on for a year or 2 years or 3 years or 4 years of treatment, there can be ongoing physical stresses that are major contributors to the problem. And we always need to look at this. And as a physical therapist, that's a huge issue. Pain is simply not just a psychological problem. People are not imagining their pain. It's coming from somewhere. Sometimes the psychological processes they have add on to it. They make it more complicated. They make that pain seem greater than it might if in other situations. But the pain of arthritis isn't coming from nowhere. And so I think it's always important to think about these physical issues, even though oftentimes when we talk about chronic pain, we tend to forget about them. So I think the biggest point about chronic pain and acute pain, you've heard all of these before, but the one that I think is most important is that this is something that people are going to be dealing with for most of their lives in most cases. So whereas most physical therapists are used to going in and seeing somebody and fixing the situation, and then it's finished. It's a whole different game when what you're doing is you're seeing somebody and you're helping them to get along a little bit better, and then realizing that this is not going to go away, but hopefully they're doing a little bit better, and then I'll see you again in a year, or I'll see you again in 6 months. And it's a whole shift in attitude and understanding of what physical therapy treatment is all about. And so I'd like to echo the point that a couple other people have said, is that when you're looking for clinicians to help you with people who have chronic pain conditions, probably the most important thing is to find somebody that's actually interested in it. Because I can tell you for sure that many physical therapists, an area that I know really well, are not interested in it. They tend to run away from this, and I think it's understandable. I think it's challenging, it's difficult. We're not always educated as much about these things. It's important that you understand that, and that you find somebody that's interested, that you can have an ongoing dialogue with. If this is going to be something somebody lives with for their whole life, you're going to have a lot of time to have a dialogue with that therapist. so no time to start, no better time to start than the present. Now this effective emotional response of pain, June Dahl talked about this earlier, and you can really divide. The signal goes up to the brain, the pain signal goes up to the brain. You can think about it dividing into two aspects, a sensory discriminative signal that helps us to understand how intense is that pain, where is that pain, is it a sharp pain, a burning pain, that sort of thing, and the effective emotional response. And that's this is the response that our brain has, and our brain connected to the rest of our body that tells us this is a major danger to myself. This is emotions on this level. This are something that's evolved deeply into us by natural selection, and we can't just ignore them. When we undergo things, when we suffer a great deal of pain, that makes us very uncomfortable, and it makes us want to stop that situation. And although we can learn to cope with that in better ways, it's always going to be an extremely stressful situation, and one that has to be monitored continuously. This is directly from a slide from Dennis Turk, who's talking here tomorrow. I'm going to echo the point that this is just a great opportunity to see him, but it really just saying some of the things that other people have said, that even in the best case, we're not looking at huge changes. Still, I wouldn't say 30 to 40% is insignificant, and most patients with chronic pain issues will be grateful for things that decrease their pain 20 to 30%. Okay, now getting into what physical therapists do in particular, I put up this whole list of stuff here, and of course it's way too busy and you can't make it out, and that's kind of the point. We can do all of these, and when you send somebody in, the therapist you see might like to do that one and that one, or that one and that one, and some of them are better for people with chronic pain and some aren't, and so it's quite challenging. And what's particularly challenging about chronic pain from a physical therapy standpoint is that some of the things that you can that will help somebody that has less chronic pain get better can actually impair the progress of people that have more chronic pain. And I'm not going to belabor the whole psychological factors thing because we've heard so much about it, but I would like to make a point that if anybody's interested in these psychological factors and a really, really excellent, simple, evidence-based explanations, this article, this reference by Keefe in the Journal of Pain is a terrific reference. So I'm only going to talk about these in a very brief way, in that these are the factors that physical therapists need to be aware of, because if you treat somebody with typical physical therapy without being aware of these things, it can often lead to a worse outcome, not just a break-even outcome, but they can actually get worse from therapy. And so if you're dealing with physical therapists, and there's some concern that maybe these issues aren't being understood, this would be a great reference and a great article to help in a dialogue there, I think. This fear avoidance model, and I'm not going to talk into it anymore, except I think Pat summarized it sufficiently, but that if we make people fearful about moving, then their outcome can be worse. And so how can you make somebody fearful about moving? Well, when somebody comes in and they hurt, oftentimes they think, well, I don't want to do that. If I walk, it makes me hurt, so I'm not going to walk. Because part of the reason there is they think that their body is being damaged. Damage is a key word there. Whenever you hear somebody say damage, you have to watch it. In chronic pain, we're not so much. The truth is oftentimes there isn't a lot of physical, easily identifiable, for example, by radiograph damage that's going on there. That's not to say that there's not changes that are going on in the nervous system, but the point from this is that if people feel that that by moving they're going to damage themselves, they'll tend to stop moving. And in the long run, people who stop moving, who stop being active, who stop engaging in their life, are going to have a worse life. And any treatment that encourages that direction is one that we need to avoid. Self-efficacy. This is just a useful concept, I think, for physical therapists to think about, and that's that what self-efficacy is, how confident is a person in their ability to accomplish certain functional goals. And we've talked a lot about function, a lot about people achieving the goals that they want to achieve. And self-efficacy refers to how confident you think you are that you can achieve those. And I think this is a really, really useful concept for physical therapists to use. And it works like this. If somebody comes in and says, I just wish I could sit up and talk with my children and my grandchildren for an hour. But I can't do it because it hurts so much. And what we can do is take a look at that as a situation where, okay, so what are the physical stresses that are involved that are contributing to this, and how can we arrange things for you? How can we teach you things that will increase your confidence in your ability to get this done? When it's all said and done, though, the long-term risk of being inactive is greater than the one of being active. If you get less and less active, your quality of life is going to be worse. And that's going to summarize it for the psychological stuff. Now, what do physical therapists do? So physical therapists do their whole deal, but what they have to be aware of is all those psychological factors so that they don't go backwards instead of forwards. Now, these are basically all the things that therapists can do. That huge page that had 55 things on it can be summarized into this. And the first one is really the most important. And there's two key words in change habits of thinking or behavior that we should especially focus on. And the first one is habits. So much that we're dealing with is habits. And habits are very difficult to change, very difficult to deal with for any of us. And behavior here I'm talking about is not just behavior, acting out, being angry, that sort of thing, but also behavior, being more active, seeing your friends more, doing more things, changing the way you move, that sort of thing. Okay. So, just like Pat said, the focus does have to be primarily on improving quality of life and your ability to manage things, and not primarily pain relief, although I think oftentimes we can neglect the pain relief side of things, at least from the physical therapy side. So, the three keys here in treating chronic pain patients, from my opinion, are to educate patients. What Patrick Wall of the Melzack and Wall gate control theory said is probably the most important aspect of pain treatment, increasing overall activity and changing postures and movements. And so as far as education, this is one that really hasn't been talked about that much today. And I think this is a really, really good thing to be familiar with when you're talking with patients, and that's these processes of central and peripheral sensitization. And why this is important is that when somebody comes into the clinic and a light touch or a small movement causes them a lot of pain, everybody tells them they're crazy, they think they're crazy, they don't know why they're crazy, that sort of thing. These processes, central and peripheral sensitization, do a lot to explain why the same input, the same pain input going into the brain can cause a very different response. And these are biochemical processes that occur in rats and monkeys and people as well. And so the more pain continues and continues and continues, the more we become sensitive at reading that signal, and the louder that signal can appear. So even as the signal goes down in intensity, it can seem just as intense. The importance of psychology consult, I'm just going to say one tip on this. I think the most important thing for me about somebody seeing a psychologist, I think anybody that sees chronic pain or has chronic pain should be seeing a psychologist or a psychological professional. And the way I explain that to the patients I see who are so distrustful of that because they think when you suggest that, they think, you think it's in my head, you think I'm crazy, that sort of thing, is to explain this is more stress than anybody is born knowing how to deal with. This is a tremendously stressful thing. I mean, I sometimes think about it and think, what would it be like to have unremitting severe pain at all times of your life? And it's just staggering to think about how horrible that would be. And yet we see people like that all the time. They can help you. They can help you to try to deal with that better. You shouldn't be able to deal with this now. This is more than most people can deal with. This is more than all people can deal with. And what's interesting is so often you tell people that, and if you look at their face, even the most stoic, the toughest people, you can just see them almost ready to cry. It's because I think they don't hear that very often. They often think that they're just crazy, and I think some understanding of that is always helpful. And then we've talked about that. Now, increasing activity. Here's just a number of the many positive things about increasing activity, and I won't beat it to death anymore. But there was something said that if 30 minutes of moderate intensity aerobic activity was a pill, it would outsell all other pills together. It's fantastic medicine. I think that was a former Surgeon General that said that, and it's true. It's just amazing stuff. And there's also a dose response where 30 minutes is good, 35 minutes is better, 40 minutes is even better still. The more we can increase that, the more we can gradually increase intensity and duration, the better a response we're likely to get. Of course, without worsening their symptoms, that's going to stop them. Thank you. Okay. Only about 15% of us get that basic amount of moderate intensity aerobic activity in a day, and trying to tell somebody who has a knife stuck in their back to do it is yes, you can say go charge, but it's helping them to do it in a way that's not going to make them hurt worse is very helpful. And what's actually kind of interesting, and this is really interesting, is that people who can learn, people who have some serious chronic pain issues, and they can learn how to exercise in a way that doesn't make them feel worse, they really feel much, much better from it. And I've seen them be much better at maintaining their exercise program over long periods of time than you and I do. It's when that pain is dramatically increased with everything they do that as soon as they get sick, something bad happens or something, the exercise program's out the door. And a real key element here is avoiding boom-bust cycling. So often what people do is they say, oh, I feel terrible, I'm lay in bed for 3 or 4 days, and then okay, I'm sick of being such a lazy person, I'm going to get out there and I'm going to walk 24 miles, and then they hurt themselves, and then they're back in bed for 4 or 5 days. Well, this is a guaranteed recipe for disaster. You get worse and worse and worse and worse when you do this, but it's very, very common. So trying to get people to moderate their activity, go forth a little bit at a time, is extremely helpful. Okay. Now, decreasing modifiable physical stressors, this is really where I get into some of the stuff that I just love to deal with. And some of it is so basic And it's really stuff that I think any physical therapist has the training to deal with. I think many physical therapists actually underestimate the importance of some of these things because they're not quite so important with people who have transient pain issues. But with chronic ongoing pain issues, they are extremely important. Yeah, I'm just going to move on and go right on to improve sleep. and this one I think is a tremendously important and overlooked factor. And Catherine talked about this earlier. I talk about this every year. You look through the literature and you look at, well, what's the effect of positioning on pain, stuff like that. There's a vacuum. There is a vacuum in the literature. But yet, I talk to people out here, I hear people say, oh, well, how'd you sleep last night? Well, when I'm in the hotel, the bed, it's too soft. Oh, it makes me feel terrible, you know. And so we all understand that we get into a bed that's not quite right, or we're sleeping on something too hard, or we fall asleep on a couch and it kills us. Well, somebody that has, for example, an arthritic condition is going to be more susceptible to the stresses that bother you and I every day. And so really figuring out how to perfect sleep, how to make it as good as it possibly can is extremely important. And so often when I'm asking people, well, when is your pain really bad? Well, it's at night. Night is horrible. It's horrific. And then I wake up and it's terrible, and it's not until 10:30 in the morning that I can start moving. I think it is very, very rare that cannot be improved. And this is not that somebody isn't thinking about their pain right. They don't wake up in the morning saying, I want to think like I'm in bad shape. I mean, they've had a terrible, terrible night, and that there's no thinking around it. So what can you do about it? Well, it's fairly simple. You take you essentially modify the positioning so that you take off as many stresses as you can on the spine. It's actually very effective. And I won't get into the details of it, except to say one thing, is that a trick of this is that you can tell people what to do till you're blue in the face. And they'll swear up and down that they understand, they've tried everything. This is something that is only effective if you demonstrate it to people, and you move them from the position that they're typically in to the position that you're showing them. And by showing them the variation of this is what it's like the way you normally are positioned, this is the way it's like when I'm discussing to you, that's when it becomes apparent. If people can see that difference, then you just say, now you add this up for today, tomorrow, the next day, the next week, the next month, and it's going to really add up to something. So that's the process to encouraging that. Improving comfort with positioning. People need to be able to sit comfortably, be able to stand comfortably. Sitting is sitting is something that can easily be changed. Anybody who happens to be unfortunate enough to be shorter than 5'4", for example, is too short for a standard chair, and that the problem with that is that when you reach to touch the ground with your feet, you pull your low back into an arch. That arch can press on the facet joints in your spine. It can increase your pain. Well, you put a little footrest that's 1 inch high underneath your foot, and you can make a dramatic difference in it. And those are some of the issues that physical therapists can get to the details of, and really provide very, very specific interventions that are designed to address the person that's actually in the room. Decreasing pain with daily activities. This one here I show getting up and down from a chair because it's very common to see this as being a very painful activity. And if you see people in your offices and you you watch them get up out of their chair and they're grimacing, I just really strongly recommend you let the physical therapist know that's something that you want them to work on, because the kind of stresses, for example, with somebody who has chronic low back pain, the kind of actual physical mechanical stresses that go through that spine can be changed by an extremely great deal by changing the way how that person gets up. If somebody gets up out of a chair like this versus if somebody gets up out of a chair like this, there is an altogether different amount of stress going through those sore joints on the order of 3 or 4 times. So getting into a summary of some of the things that really aren't ideal for people with chronic pain and that you might see with some therapists that you're dealing with is excessive use of passive modalities. Now, I said earlier, I don't have any problem with just anything that you want to throw on there. It's expensive, but it might not, if we can afford it, we'll go for it. Well, that's not exactly true. I think we do need to be aware that there's a lot of information in the pain literature that suggests that if we do things that cause patients to become more dependent on us, well, of course, that's not leading to them becoming more independent. And so if they're coming into us to feel better, and then they come into us to feel better, and the only way they can find to feel better is to come into us, they lose the sense that they're in control of their pain. I think another thing that on the other side here is ignoring pain. And sometimes we've reacted to this idea that, well, we don't want to focus too much on your pain, we want to get active, but to taking that too far and saying, well, just ignore that pain, keep going, you're fine. And that's very easy for the therapist to do, but it's very difficult for the patient. And oftentimes the patients will be, they will want to perform for you. They want you to think they're trying. They want to try themselves, and they'll go through with this for a while, pushing themselves. But then when it comes back to, okay, now you're off on your own, you've got to take care of things on your own life, that things don't work out so well. Okay, I'm out of time, but I am going to take about 1 more minute. So encouraging fear by not dispelling the myth of pain is equal to tissue damage, and this is what I talked about earlier. Pain is not equal to tissue damage when people have chronic pain. They can have extreme pain. You acknowledge to them that pain is extreme. It does not necessarily mean their tissues are continuing to be damaged, okay? And that's an important distinction. So that when people hurt, they're not necessarily causing damage. I think that's important to stress. Not increasing activity, we've been there, and that. Okay, overall, we've talked about that as well, and I'm done. Thanks.
You want to give that to Leanne? Sure. We've got one more presentation before the break. Is that right? Correct? And so the next presentation is going to be on the pharmacology of complex chronic pain patients. I'll make a couple of comments about Nelson's presentation, a couple of key points. We just tell people flat out when they come into the Montana Spine and Pain Center for treatment, if they're going through the chronic pain program, that if they're unwilling to participate in increasing their activity, that we're not going to be able to manage their pain, period. So everybody has to generate some sort of a program with a physical therapist to increase their activity level. The second thing I would tell you is that if you send a chronic pain patient to a physical therapist for a month of therapy, and they come back and tell you that the therapist said, I'm hurting too much, so they just put electrical stim and some hot packs on, you need to find another physical therapist. On the same thing, just what Nelson said, if you send a chronic pain patient to a sports medicine physical therapist, They will be back before the month is out. And that's not going to work either. I think you have to really have a physical therapist, as he said, who's willing to engage the patient authentically and really work to help that patient generate a self-care program. Because too many patients go with the notion that I'm going to a physical therapist, what is he going to do to me, or what is she going to do to me? That's not the point. The point is that that person is going to coach them to get into a place to where they can move forward with their treatment program, which is the rest of their life. So keep that in mind, and we'll move on to pharmacology.
Okay. My name's Leanne Bradley. I work with the Montana Spine and Pain Center. I'm a pharmacist, and I get to be part of a multidisciplinary team. Is this off? Is this on? Okay. Is that better? All right. And so a lot of our patients come to our multidisciplinary pain center with the expectation of course, having their pain evaluated and treating, and to most people, that means drugs. Hopefully, that's not necessarily, what happened to my case? Necessarily the entire focus by the time we're done with them. But going back to Dorothy that Janine presented this morning, just, you know, by the time, it's not uncommon for us to get a failed back syndrome. And as June mentioned this morning, the nociceptive pain, neuropathic pain, both the mechanical and the neuropathic pain, what I'm going to talk about is rational polypharmacy to treat these people. A lot of times, I love this picture, taking down the Bitterroot, and I think it was year 2000 for the fires. That neuropathic pain, just patients identify with what that looks like. And so goals of talking about polypharmacy, most pain studies that are done consider a 30% response rate successful. Now, if you got 30% on a test, you don't usually get to pass. But 30% tends to be kind of hard to do. But it does correlate with improvements in quality of life and subjective reports that pain is much improved. If we had one magic pill that made everybody's pain go 100% away, that'd be wonderful. But we don't. And for chronic complex pain, it often does take, if we're going to treat with pharmaceuticals, it can often take a polypharmacy. Now, while we don't like to do that with most conditions, we like to, you know, treat with the fewest drugs possible, it does make sense in a complex patient. It is difficult to achieve greater than 30% reduction. It's not advancing. Okay. Another goal of therapy would be to increase the dose only after the patient tolerates the last dose. A lot of drugs we use have a lot of side effects. You can become tolerant to the side effects as you're exposed to the drug. But if you go too fast, they're going to think they're having too bad of an adverse drug reaction, and they're going to think they failed the drug, and you can lose one valuable way to treat it. You can also, if they're getting benefit from the drug, try a higher dose, and if they don't tolerate it, go back to the lowest dose that they did tolerate and get benefit. And hopefully they're getting somewhere around a 30% response to call it a therapeutic success. When you're looking at polypharmacy, what you want to do is pick drugs with different mechanisms of action to target different pain pathways. With that pathophysiology slide that June had, you could see the different transmission, the afferent feedback, the modulation. There's all these multiple places that can be targeted to help modulate pain. We want medications, sometimes they're synergistic to improve overall efficacy, such as adding an NSAID to an opioid is pretty much considered to make both better, and patients get better response with fewer side effects because you can use lower doses of both drugs. Different medications with different side effect profiles too. You don't want to pick two drugs that are both really sedating if you can pick one that isn't, because you're more likely to have less sedation if you don't have two drugs they're sedating. And chronic pain, of course, is defined by long term, so patients do want, they've been living in suffering and pain for a long time. They do want an immediate fix. By definition, this chronic condition is going to take time. If we can only get a 30%, hopefully, response rate if we pick the right drug at the right dose the first time, and we do have to titrate, and we will have to, perhaps the first med we didn't pick didn't work, we got to try a second one. It takes time to do this. Ideally, it would be best to start one medication at a time so that you know what the side effect profile is and what the benefit is, or stop one medication at a time to know that if you stopped it and they did have more pain, that was beneficial. So many of our patients come on 5 or 6 or 7 meds and can't tell us which ones are working and which ones aren't. They were all started at the same time, or their ability to recall over time when they were added and how they responded, or if they're having any side effects, which one's causing it. So ideally, it's best to start one at a time. And the patient's expectations have to be reasonable. Identify functional goals prior to therapy. That's especially important with the opioids if we're going to justify our use of the opioids. And start patients with multiple chemical sensitivities on like the lowest dose possible. Pediatric doses, go slower. Try not to lose one of your good options because they didn't tolerate that drug. And that's really common to see these long lists of intolerances on patients. So the patient presents, they have complex chronic pain, probably both nociceptive, neuropathic. What do you start with? By the time we get patients, they've been through multiple providers, multiple meds, depending on what they're on, what their history is, what their allergies and intolerances are, what their comorbidities are, and the type of pain will help direct the choice of the drugs. And so when you're looking at rational combinations too, the different mechanisms of action and the sites of where they work tend to be important. There isn't really a lot of rationale, I don't think, for being on more than one long-acting and one short-acting mu-opioid receptor agonist. There isn't any rationale to be on more than one NSAID. Anticonvulsants at this point, even though they have multiple different mechanisms of action, it's, that's not, generally we don't add 2 anticonvulsants to people. Lidocaine and capsaicin can work on the peripheral central nervous system when applied topically, so if you only have centralized pain coming from the spinal cord, those don't make much sense. But you can see that they do have multiple different mechanisms of action to help guide. And as Janine mentioned this morning, these are some of the other options for neuropathic pain. If you have an acute flare where there's nerve irritation or tumor pressing on a nerve, steroid burst can be beneficial. Lidocaine patches, capsaicin, and if it's sympathetically maintained pain, the alpha-2 agonists can be beneficial. But what I want to concentrate are on the very first-line drugs. First-line drugs, and for neuropathic pain, which Dorothy's presenting with that pain going down her legs, are the antidepressants and the anticonvulsants. Opioids are just as effective as those drugs for neuropathic pain, but the risks and the side effects tend to be greater with the opioids. So generally they're listed second or third line on most guidelines, and you really do, if you can, optimize your non-opioid medications first, and then see what's left over to treat. Now, if somebody presents in really severe pain, that may not be reasonable, but it does make sense to try and minimize the amount of opioid that we're going to expose the patient to if we can. Our goal is not necessarily the lowest dose of opioid, but if we can use lower doses of all 3 drug groups, overall we'll have fewer side effects and potentially better pain control. And you've seen this slide. Their dose ranges differ depending on what guidelines and references you look at. 10 to 150 milligrams, 10 to 100 milligrams. with the tricyclic antidepressants for decades have been the first-line drugs for neuropathic pain. They are used in lower doses than antidepressant doses. They for neuropathic pain control. The actual analgesic effect is independent of the antidepressant effect with tricyclic antidepressants. And so you can get by with less side effect than we used to have when we used them as an antidepressant, because we can get by with lower doses usually for these patients. And the second generation are definitely better tolerated than the first generation. That first generation amitriptyline, I don't know very many even young healthy people that like amitriptyline. But definitely in the older patient, if you're going to try a tricyclic antidepressant, you want to go with the second generation. The SNRIs, the serotonin norepinephrine reuptake inhibitors, which help modulate that, which help improve modulation of the spinal cord message to the brain. Duloxetine, one of the things to look at is the hepatotoxicity. We have so many patients with Hep C, or if they've had alcohol abuse in their past, or if they have any kind of cirrhosis in their liver, that's a contraindication to using Cymbalta. Effects are really at the higher doses, the 225 milligrams per day, finally becomes a balanced norepinephrine serotonin agent. So you really do have to push the doses on that usually to get neuropathic pain control. In lower doses, it's just norepinephrine activity. And then Savella is the new one on the market that it's been in Europe for a long time. At least it gives us a third option to try here. This is just a little more information. As Janine said this morning, SSRIs are not effective for neuropathic pain, but when you look at guidelines, you can get pretty confused because they'll list some of them in the guidelines. Wellbutrin gets listed in one, but there was one study in 41 people that showed benefit in neuropathies, and the SSRIs have two small trials, one in Paxil, one in Celexa in diabetic peripheral neuropathy that showed benefit. There's at least 19 published negative trials that say they don't work. But they get into the guidelines because there are so few randomized published trials. And so it gets confusing when you look at that, but when I see that there are multiple negative trials and you know the literature is skewed to positive trials, what drug company is going to publish a negative trial about their drug? You know, the data is skewed to positive trials. That when I look at this kind of data and see that there's been one small trial with paroxetine for neuropathic pain, it's definitely not one of my first-line choices. You have to be careful to screen out bipolar patients because you can exacerbate or throw them into mania. The black box warnings regarding increased suicidality when you're first starting a patient with depression on an antidepressant. And we do see a lot of patients on multiple serotonergic agents, 4 or 5 of them at a time coming into us. People have just added one after the other. There's no benefit to doing that, and you do put them at increased risk for serotonin syndrome and probably, you know, exacerbate their anxiety, their depression is no better, and all those things. And so you got to look at what drugs you're adding together, and if you're going to use multiple drugs, try to get different mechanisms of action. The anticonvulsants used to be second line after the tricyclic antidepressants, but they have moved into first line also. If neuropathic pain has similar pathophysiology to epilepsy. And what you're doing with these anticonvulsants is you're decreasing spontaneous firing of those sensory neurons to calm down the nervous system. There are multiple different anticonvulsants. All the mechanisms are not understood. There's two kind of big groups, sodium channel blockers and calcium channel blockers. The gabapentin and the pregabalin in this alpha delta 2 tend to have the best data right now for neuropathic pain control, but some of the other ones do work too, and they're very good mood stabilizers. You know, even with people without bipolar will sometimes say after we put them on something like pregabalin or gabapentin that, well, they don't know how well it's doing for the pain, but they're certainly coping with their pain better. And they prefer to stay on it because they see that they feel like they're coping so much better with the pain. The first generation drugs, there's a lot of monitoring for liver toxicity, CBCs. serum levels. Clonazepam has some dependency issues with it. And so the cost, even though they're very cheap generics, and even though like carbamazepine is a first-line drug for trigeminal neuralgia, the monitoring and the adverse side effect profile, that's why these were not in first line like the TCAs were at first. But since the advent of these second generation agents, they are so much better tolerated. There's so much less monitoring associated with them that's what makes these first line now. And Lamictal, I just want to point out, it's your drug of choice in treating bipolar type 2, which is primarily depression, because it's the only anticonvulsant that has antidepressant effect also. So that can be beneficial when you're looking at picking drugs to help treat more than one comorbidity. And it can be very effective in some patients for neuropathic pain. There's a few other little different things. Topamax, there's a couple of negative studies for different neuropathic pain conditions. And there's 15 minutes. And there's a couple positive studies. Overall, it's not like one of your first line choices, but definitely migraine headache prophylaxis. Lacosamide's brand new on the market, and they are right now doing studies for diabetic peripheral neuropathy. It's probably going to get indications also for neuropathic pain. So what are we going to do with Dorothy? We have all these choices of what to pick to add to her regimen. We could give her an NSAID. We could give her a steroid. We could give her, calcitonin biphosphate for vertebral compression fractures, new fractures can be beneficial. She doesn't have that. We don't know that she has osteoporosis. How about acetaminophen? Do you think acetaminophen is going to be very helpful for her? Probably not. So with her component of nociceptive and neuropathic pain control, what do we want to try first? Yeah. Probably an anticonvulsant or tricyclic or one of the antidepressants that would work. So, but most of these people don't come really without any history behind them. So if you have more information, like she's currently taking OxyContin 40 every 8 hours, she's high risk for cardiovascular disease, she cannot sleep at night due to the pain, she's depressed, she's had a weight loss of 15 pounds, she's low risk for opioid abuse. Now what do you want to do with her? Do we want to add an NSAID to her? No. High-risk cardiovascular disease. Do you want to increase the opioid, decrease the opioid, change the opioid? Do you want to, acetaminophen probably isn't going to add a lot at this situation. So we could try and treat with a different drug, with a different mechanism of action, and choose an antidepressant or an anticonvulsant. She's got depression. We could pick an antidepressant. So 6 months later, she comes in, and her mood she's improved functionally. Her depression is in partial remission, and she's on gabapentin 800 Q8, and you've got an anticonvulsant. Dizipramine 75 milligrams at bedtime. You've got a tricyclic antidepressant. OxyContin is the same, and we've had to, of course, treat the constipation. And dizipramine, there was an interesting study a year or two ago looking at a cost effectiveness of dizipramine versus gabapentin versus pregabalin. And the outcome was dizipramine was more effective and certainly less costly. The side effect profile was 24% of the pregabalin Lyrica patients had discontinued versus had significant side effects versus 18 with dizipramine. And so the side effect profile, wasn't that much worse. How many of you have had Lyrica cause swelling? There's quite a few people end up with that one. So anyway, it was just very interesting to look at dizipramine had actually a 67% significant pain reduction versus 42% with pregabalin, I think. And gabapentin was slightly more effective than pregabalin. So sometimes perceptions, I think individual patients will respond very differently to different drugs, but I think sometimes we've forgotten about how useful those tricyclics can be. But Well, she's actually, I think she was supposed to be 75. So her Medicare Part D changed their formulary in the middle of the year, and they will no longer pay for the OxyContin, and she cannot afford it. So what is our most cost-effective medication? And I was going to talk about methadone because, not to push prescribing of it, but because there's a lot of it around and there's a lot of misinformation, and definitely the unintended overdoses have been increasing. It tends to be a very dangerous medication. Oops. And so it is very effective analgesia. It's very inexpensive. You know, $30 or $40 a month replaces hundreds of dollars a month patients pay for these medications. Inherently long-acting, and it's the only one with a liquid form that is long-acting. And I'm not going to go over all these slides, but I'm going to tell you just a couple. There's way too much pharmacokinetics here. I'm just going to tell you a couple of the bullet points here. No active metabolites. There is less tolerance than with other opioids. And there was a really nice study in 1998 looking at dying, end-stage terminal cancer patients, and they looked at them in their last months of lives, average length, I think, was 60 days. And they looked at one arm on methadone, one arm on morphine. And in the morphine arm, you kind of expected with disease progression and tolerance to have some escalation in the morphine arm. In the methadone arm, after the first week, it stabilized, and there wasn't any progression. And the average dose was 18 milligrams per day, and they were all within 10 to 40 milligrams. So tolerance tends to be not as much of an issue with methadone. There is some serotonin norepinephrine release, so there's some thought that maybe it's better for neuropathy, but the two studies I've seen head-to-head were methadone versus morphine, and I think one was in HIV patients. Anyway, they didn't show any benefit for the methadone. So I haven't really seen that clinically or proven, but you see it in the literature all the time. Let's go. Here's the biggest problem is the half-life is huge range. Average around 24 hours, but the range is 15 to 130 days, 4 to 10 days to achieve steady state. But the duration of analgesia is 6 to 12 hours. So for most people, you're giving it about every 8 hours, but it is going to accumulate because its half-life is over 24 for most people. Very long and highly variable, so you can't really predict it. And it's still active at the respiratory depression, sedation receptors, even though it's no longer working at the analgesia receptors. I have no idea what the explanation for that is, but you need to dose it more often for pain, but you still have the respiratory depression risk there. It's extensively metabolized, but there's huge differences amongst patients. There are drugs that cause it to accumulate. There are drugs to cause it to be inhibited. But even these drug tables change. I mean, I just read a study where some of these HIV drugs where they did serum levels on patients and it didn't change the methadone level. So there isn't a lot of black and white to take from the methadone information to tell you exactly what to do. There is, I found some recommendation that kind of makes a little sense that if you're worried about adding a drug that has been identified as causing accumulation of methadone, you can reduce the dose by 25% and hopefully cover them with a rescue med. So there's some practical recommendations, but you can't really predict what's going to happen in a patient. And this year, there's the new cardiac warnings that Janine talked about this morning, so I lined them out. They were written to ensure the cardiac safety of patients on methadone. The first information that came out on methadone was in doses over 300 milligrams a day, you could prolong the QT interval. Then there was some literature saying over 100 milligrams a day. And so I was kind of surprised when these guidelines came out and said, just pretty much you need an EKG on everybody. I think the natural incidence of prolonged QT syndrome is 1 in, I saw 2,500 to 7,000 people. So there is a natural incidence of it that you're not going to be able to predict. So safety-wise, it would be best to get an EKG on pretty much everybody, because that's what the printed guidelines also now say. So who's appropriate for methadone? there are very few true allergies, but methadone is structurally unrelated to all the methadone group, and it's unrelated to fentanyl. So it is structurally different from those. Significant renal impairment, neuropathic pain, opioid-induced side effects. You can change from one opioid to another, and they may not have as many side effects, and they may get better pain control. It's definitely the most cost-effective. If you need an oral solution, you do need a compliant patient, because you can't have a patient taking a PRN because what they take extra today is going to show up in 2 or 3 days. That's the biggest problem. That's how you get accidental overdoses on methadone, is either the patient is non-compliant and or they're looking for mood alteration, and methadone has very little mood alteration for most people. If they're trying to get mood alteration and they keep taking more of the methadone, they're going to eventually overdose themselves looking for that. Or if they just, are not a non-compliant patient. And I can't predict compliancy. Some of our best educated, intelligent people who tell me they're going to take it exactly like I prescribed, if you count their pills when they come back, they have not been taking it as prescribed. That's their control, and they're going to take it, and they know what they're doing. So you do need to ensure some compliancy in these patients. And it is a drug of choice in a patient who has a history of addiction but is compliant, because you don't have that mood alteration for these people. Package insert recommendations are to start very slow. They don't even make a 2.5 milligram tablet. You're having these. You don't increase the dose very often. The echoanalgesic dose charts are not accurate. They're based on single doses, so even the chart that you have in your packet lists the 10 milligram dose, but it does say only people experienced with methadone should be using it. So here's the best conversions that I could find, and I just think this is amazing. The more opioids you take, the less methadone you need on a ratio basis. It is very, very potent. You don't, and in 1996, when we started the pain service at St. Pat's Hospital, we had somebody come in on 250 milligrams of methadone. And I promised him, yeah, we'd give you whatever you needed post amputation. He had to have an amputation to control that pain. We used every milligram of dilaudid we had in our pharmacy. Well, I estimated from this table that he'd need 22 milligrams of IV hydromorphone dilaudid to replace the methadone he was on, and then he'd need a little extra for the acute pain. He took 700 milligrams IV over 5 hours before he relaxed his hands and related his pain 7 out of 10. No sign of sedation, no sign of respiratory depression. The methadone is incredibly potent. And then in 1998, they published that methadone is incredibly potent. So there's a couple conversion tables that you can decrease the opioid that the patient's on by 30% each day and let the methadone accumulate, because the methadone needs to accumulate, okay? Or you can stop the other opioid, give the methadone at fixed intervals, use the conversion ratios to predict it, and give breakthrough, short-acting, to try and do that. There's other recommendations to never go over 30 to 40 milligrams a day, regardless of how much other opioid they're taking. And there's the famous go start low and go slow. There's no recommendations to convert from methadone back to other opioids, because if you look back at that chart, and somebody is on 250 milligrams of methadone, what ratio do you pick from that side going across? There are no recommendations there. So, you kind of have to, try to taper the patient on the methadone as low as you can go, and then start the other opioid. And a lot of times they don't take as much as you're going to expect. It's a different opioid. People over time don't respond to them the same as they did when they started it 10 years ago, that kind of thing. So it's kind of, sometimes you end up with a lot less than you expect on the second opioid. So opioid failures. If you give an opioid to a patient, what do you call a failure? If you put them on a trial, not all suffering responds to opioids, unfortunately. It's a good drug for those conditions that are nociceptive, neuropathic, but not all suffering responds to opioids. So generally, if you have increasing pain despite giving reasonable, like Janine said, those 20, reasonable increases in the opioids, several trials, several increases, 2 or 3 different opioids. If their pain is still the same, if they've decreased their function, if they want to keep taking it even though they're being admitted with small bowel obstructions, obstipation to the hospital, even though they've had to be Narcan for respiratory depression, that is a red flag, okay? Or continuing aberrant behavior despite education. If you can't, everybody screws up sometimes. Everybody makes bad decisions sometimes. If you can't get them to be compliant or make good choices, they may not be safe on it. But it would be continuing aberrant behavior. So that's it.